Just a reminder that this meeting is being recorded, though it's not being streamed live. We have a revised agenda so that this recording will air on the Metro Nashville network tomorrow at 9 a.m. on Comcast channel AT&T First Channel 99, and then the Google Fiber Channel 3 and MNN Roku channel and Nashville.gov. Okay. So let's also, as we let me take roll just so we can assure that we have quorum. It looks like from people registered we do, but let's go ahead and get an official roll, and then we have a couple more business items before we hit the agenda. Angie Thompson. Here. Katina Beard. Shotzi. Here. Monty. Here. Judge Calloway.
Here.
Judge Eisenstein. We saw you.
You want?
Robin Noble.
Here.
Jamison Norton.
Here.
Mary Linden. Looked like you were on. No. Mary Linden. May just be muted. Looks like you're registered. Pamela Sessions. Dr. Stovall is a...
Here.
That's Pamela. We know that Dr. Stovall called in for an absence. Dr. Webb. And Pam Womack, we can see and hear too.
Yeah, I'm here.
Thank you. So the second order of business after we just announced the recording of this meeting is just in accordance with other council procedures. I'd like to get a motion that our council is willing to conduct business in a virtual setting. So I would look for that motion, look for a second, just to acknowledge that we're conducting virtually. Do I have a motion?
I so move.
Who is the second?
Robin.
Thank you, Robin. All those in favor?
Aye.
Aye.
Aye. Any opposite? Okay, so hearing none, approved. In your packet, we have minutes. The agenda stated that we had minutes from June 22nd. The packet also contains minutes from June 4th. So first order of business is I'd like to get a motion to include then the June 4th minutes as an action item tonight. So if I can get a motion to include the June 4th minutes.
So moved.
Second.
Second.
So let's vote on that. All those willing to include the June 4th minutes, an official part of our agenda, indicate by saying aye.
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 Any opposition? Okay, so now we're taking both the June 4th minutes and the June 22nd minutes for your consideration for approval. And I'll entertain a motion, and we'll assume that both of those are taken together.
This is Robin. I'd like to put forth a motion to accept both of those together.
Thank you, Robin. There's a
Sheila
second.
Calloway, I'll second.
Ms. Calloway. So we have a motion and a second to approve the June 4th and June 22nd minutes. All those in favor?
Aye.
Aye.
Any opposition? The minutes are approved. Thank you. So the next order of business here is to really provide an update on the status of our COVID-19 behavioral health recommendations to Mayor Cooper. I really want to start, and I know I'm speaking for Angie here as well as for Dia. I just want to thank again this council for the time and effort and the work put in to getting us as your co-chairs, and Dia, and the support that she provides us to a place where we actually were able to, reduce our collective thoughts as a council into some meaningful asks and put those asks before the mayor. And, you know, all this really sprung from the mayor coming, being with us in a very personal way at our recent council meeting, asking us very clearly, right, to put forth actionable recommendations that aligned with our shared vision for behavioral health services in Metro Davidson County. And again, just gratitude, kudos to the council for coming up with very, very actionable items that we were able to pull together to categorize right into those areas of need, those areas that absolutely align with the shared vision that the mayor began by articulating himself the last time he was with us. So all that was done. We had 2 follow-up calls, and again, thank you for all of your time and effort in joining us for those calls. Those calls really allowed us to vet and discuss through those items, and we were able to condense all that time and effort into, you know, a couple of pages, very concise items for recommendations for funding under COVID-19. So I want to give Angie a chance to really talk about where the process has gone from there. I can tell you that after our phone calls, our follow-up calls together, lots of effort, obviously, that again, I want to recognize Dia's efforts as well here in helping us coalesce and assimilate all that information. We had several meetings with the mayor's office in getting some guidance, pulling that information together. We were asked on more than one occasion to, the best we could was try to quantify that ask, you know, not only the general ask in terms of quantifying the total dollars that we thought would be necessary to sufficiently fund what we as a council identified as needed gaps and what we also thought were future emerging gaps based on the data that we're seeing, coming from our respective organizations, coming from organizations outside that are represented by the council. But out of that view, what we saw as current needs and emerging needs to really meet the behavioral health care needs in Davidson County, and we did that. The approach we took in the end was to sum that up. We needed a total dollar amount, and you saw that, and we ended up with capturing a $5 million ask that summarized categorically all of our asks and also included the behavioral health needs assessment that this council has prioritized now for a year and a half, right? And we know that that needs assessment has gotten further importance while we're going through this COVID pandemic. So we know that's necessary for not only current planning, but also for future planning in the way that we envisioned that, like I said, almost 18 months ago. So that's where we ended up. I can, again, have Angie talk about how that now has moved to the mayor's COVID-19 Financial Oversight Committee and actually how the Department of Health right now, how that request is coming through the Department of Health. So let me just turn things over to Angie. Unless you have any questions before Angie starts that part of the presentation. Okay.
Okay, thank you, Bob. I think a couple things to think about with this is how did we come up with a $5 million ask? And we knew there were $55 million on the table that were yet to be allocated. We knew that healthcare spending around behavioral healthcare spending compared to all spending is 3 to 5%. So we went with a 5% number. And so that's how we came up with our $5 billion. There really wasn't another way to quantify all these items in any way that would be reasonable to try to explain. So that's how we came up with the $5 million number. Then once that number was arrived at, we had to think about how could this money be dispersed and what would be a process for that. So the health department has a process, while Metro has had a process called Community Partnership Fund Grants. And those, over the past few years, Metro departments were given a certain amount of money. They basically issued an RFP, and then people would, send in their proposals, and those would be funded and then managed. So they'd be managed from not only a fiscal side, but also from accountability side. So that was what we chose to propose to the Financial Oversight Committee. So at that point, Bob pulled out because this is an MPHD request. So we have requested that, and it breaks out to recommendations 2, 3, and 4, 1.586 million, and for recommendation 5 is the 240,000, and that is the behavioral health needs assessment. I will say I've had additional conversations with the folks at SRI, and that is the Human Services Research Institute. As you all recall, when we did our due diligence in terms of determining who might be an appropriate source to actually conduct the behavioral health needs assessment, they were identified, and subsequently I've had some conversations with them. What they've said is, if the money's granted, they will ensure that we get the product in a timely manner. So again, that's where that stands at this point, both for those. I don't know if any of you all had an opportunity to watch the COVID-19 fiscal or Financial Oversight Committee meeting, but the first week they sent to the council a request for $10 million to go to United Way to cover basic needs, including rent, utilities, and food. And their goal was then they had to get something in to the council on the 3rd. For the 3rd. And then they're going to come back week after week and continue to allocate funds. So we know we're still in the hopper, and so we'll just be monitoring that and following up with that. There is an individual in the mayor's office who is responsible for that, Ashley Warrington. Ashley Warrington. So this request went from the Metro Health Department to Ashley to be presented to the committee. And that's just has been the flow of how we've gone from our establishing these needs and recommendations to seeking funding for that. Any questions?
Just a reminder, prior to the materials for this council meeting, each of you received, right, the final summary document of the ask, as well as the cover letter to the mayor. So that's what that's recommendations 2, 3, and 4 are really the Roman numeral, the recommendations in our document. So that's the reference. The 1.58 for each of those areas is really arithmetic. We started with backing out the cost of the needs assessment and then looked across those areas. And again, without doing a real deep dive into the multiple actionable items under each area, we thought that in fairness, each of those areas really deserved equal recognition and potentially equal financial support. So, yeah, again, it was really just arithmetic and division over those other areas. We also spent a significant amount of time looking at your recommendations and the feedback that we received from others around existing services, where a lot of these dollars would be used to enhance current programs. And I think, that's an essential part of your consideration, and it was ours as well. We pulled the final recommendations together. So in some cases, new programs, in many cases, expansion of current programs, right? So just as much as those dollars could be used, in a way to maximize return on investment to the community was a major consideration in pulling together those asks. That's where we landed. Questions on the final document or the letter to Mayor Cooper? Okay.
Very good. Okay, the COVID-19 Behavioral Health Needs Assessment Survey of Gaps. You have in your packet a series of FAQs on that. What we were looking for, what we wanted to present to you was information that would kind of refresh the group's memory on what the purpose of the assessment was, how that would benefit Nashville, why it's important to conduct it during the pandemic, and the types of questions the assessment would address, and then the cost. So this is just a one-pager that is a simple way to look at the scope and the purpose and scope of what we're wanting to move towards. And then we have the, we're going to do the provider survey too right now. Okay. So then one of the other things we talked about at our last meeting was doing a behavioral health provider survey. And so in that survey, Bob, Vero, and Jeff Stovall, Dr. Stovall, were really instrumental in helping to shape that. And kudos to Dia for pulling the initial draft of that together. We had an opportunity in some of the discussion with the with HSRI when I was trying to get more information about if we got this money, how would this go forward. They actually agreed to or offered to look at the survey and be able to, so that we could use this as a part of their overall assessment should this go forward. So we're very fortunate to have that. So it's really designed as a first step to gain information from behavioral health providers. It really addresses two questions, which was how has the pandemic impacted the program services recipient population, and second, how has the pandemic affected program operations? And it's also designed in a way that it could be distributed again to look at this on a longitudinal basis. So looking at how circumstances change, what's impact. So the survey is going to be sent to behavioral health survey to the providers in Metro Nashville, targeting members of the BWAC and also the Community Mental Health Systems Improvement Work Group. And so if you look, when you take a look at the survey, you'll see that you're going to it'll collect information on priority needs of the client populations, looking at how COVID has impacted both staff and clients, and how client populations may have changed as a reflection of the pandemic. It also wants to examine the impact of telehealth capacity, what's there, what may be able to be used there in the future, and then how things are reimbursed and how providers are approaching future use of telehealth. And I know we had quite a bit of discussion last time that telehealth is not the be-all and end-all, but we do know that that has become a tool that people are using now. So we wanted to capture both what's going on in your encounters with your patients, no matter what that encounter is, whether it's in person or whether it is a phone contact or if it is a televideo, whatever that is, to really kind of gain information on how this could inform our work going forward. So that survey is going to be fielded in August, and you will get an email on that. We ask you to please turn that around as quickly as you can. Again, knowing that it's something that we may be able to use, or we can use, actually, if we get the larger BHNA funded.
Yeah, since my name was associated with that as well as Dr. Stovall, look, on the front end, I'm going to tell you it's a bit Herculean. It will not be a fill the survey out in 5 minutes. We are asking for some pretty detailed information, and again, we may be trying to address. We are trying to anticipate, right? Being able to use this for multiple purposes. So that's the approach we're taking on the front end here, asking for some pretty detailed information, and we know the more accurate and detailed information we have, hopefully we won't have to come back with too many future assessments and ask similar questions. So if you'll keep that as a lens when you open that survey, I think that'll be very, very helpful. But it's probably something that's going to it will take a little bit of time in each of our respective organizations and organizations outside of those represented within the council to complete as well. Involve your finance departments, involve your operations teams as we're looking at dollars plus staff impact, probably HR and service levels. So it's going to take a collective effort within each organization to complete. I think we'll be very, very pleased, though, with the results.
I think another component of this is this could also be used as a springboard when we do get some behavioral health needs assessment money, that the HSRI could actually use this to guide key informant interviews. So we need to look at it as work that can stand alone, but also pre-work to accomplish the larger mission.
Any discussion here, questions? It's feeling a bit like a monologue.
I know. Well, the audience is
just, I think this, the next item here on our agenda on our current council vacancies is as much of a reminder and placeholder as anything, just to let you know. Obviously, our candidate interview review process was intentionally put on hold during the pandemic. Dia is going to be working with us to go ahead and schedule some video conference meetings with those candidates, and we'll pull together our nominations and governance committee just to get that process moving forward. So those of you serving on nominations and governance, you'll be hearing soon from Dia, looking for some times that we can get together and then it starts interviewing potential candidates. And remember, we will be making recommendations to the mayor for approval of those candidates, and those individuals know that, obviously, as well. They are really just giving us the ability to, should the council agree, to move their names forward for consideration.
Yeah. Okay, so it is a real pleasure for me to introduce two of my colleagues here at the Health Department. Trevor Henderson is our opioid overdose response coordinator. Trevor's waving in the background. And then Josh Love, and Josh is an epidemiologist here at the Health Department. Wait, Josh. Yeah, you can run this one.
We're gonna switch seats so you can see Trevor and Josh.
And then you'll have them. So we need to share.
Hi, everyone.
Josh is an epidemiologist. He's been at the Health Department for a few years and has recently joined the behavioral health group, and so we're very excited to have him be a part of our division at the Health Department. And they both have really done a tremendous job in pulling together data. Can you give it up there?
It opened up there.
Oh, there. Okay. Okay, through the wonders of technology, it actually worked. But again, they have done a tremendous amount of work, have really built this work from the ground up. There has not been a template. They're actually creating templates, and they're creating processes that we've had inquiries from other groups from the state and then from other groups across the country in terms of the work that this is moving forward. It's really cutting edge work. So I will turn this over to them to provide an update on the overdose epidemic.
Okay. Thanks, Angie. Good afternoon, good evening to everybody again. Good to see you all. Thank you again for the opportunity to update you all on the overdose situation. Well, I also in particular thank Angie and Bob for just their ongoing interest, support, with all of this work. We really couldn't do it without both of them, actually. In a moment, I'm going to hand the presentation over to Josh to take you through some updates with the data. And just after that, I will take everyone through some updates of some of the efforts that we have going on to try and address the issue. I know I'm in good company with a lot of people here on this presentation who are doing a lot of work around this. At this point, I'll hand over to Josh.
Hi, everybody. So it's good to meet everybody, and I'd like to just go over some high-level data with you all, and if anything jogs your, if you're interested in seeing anything more after the presentation, I implore you to reach out to me and be happy to look into it. So the data provided in this report are analyzed by utilizing our locally developed drug overdose data surveillance system. It allows our team to stay situationally informed of acute events and emerging trends regarding the drug overdose epidemic. The metrics I'll go over are derived from 3 of our data sources and are monitored daily to understand the following. And those are EMS response to suspected drug overdoses in the community, non-fatal drug overdoses admitted to local emergency departments, and fatal drug overdoses that are reported from the Davidson County Medical Examiner's Office. It's also important to note that while the COVID-19 pandemic has impacted the mental health and wellness of our community, the local drug overdose epidemic has been growing for several years and markedly began to intensify around the end of 2018. Here, the figure on the right denotes the number of fatal drug overdoses in Davidson County by year. Last year, Davidson County reported 468 fatal drug overdoses, the highest number on record. Through the end of July this year, there have been 360 overdose deaths with an average age of death of 40 years. Another way to look at it is in terms of years of life lost, which is a measure of the average years a person would have lived if he or she had not died prematurely. The deaths reported so far this year average over 35 years of life lost per person. Compared to the same time last year, fatal drug overdoses are up 40% and are on pace to eclipse 600 deaths this year, and could be as worse as upwards of 650 given where we were at by June 30th. The principal driver in these deaths is fentanyl, which has been present in 75% of toxicology reports this year. In the years prior, fentanyl was present in about 60 to 65% of toxicology reports. Again, coinciding with the COVID-19 pandemic, we have observed an increase in the amount of fentanyl in the community, especially in recent months. Okay, and so here is, I also, I still kind of do all of our COVID data. So this is, I do the COVID map that you probably saw in the news. So this is in the same vein. This is a heat map showing our fatal drug overdoses this year through the end of July. And you can kind of denote, I labeled with zip codes, but you can see where hotspots are, and just, we can take a moment to just kind of look at that. It's important to note that what we've observed this year compared to previous years are, let's say, amplification of, overdoses in general in certain zip codes, while other hotspots have emerged this year. I mean, it's essentially spread all over the county, but just worse in some areas, while there's some new areas that have come about. And we, are privy to this information due to our surveillance system. So, so similar to fatal drug overdoses, non-fatal drug overdoses have been on the rise as well. The figure below compares overdose emergency department visits from January to July, comparing 2019 to 2020. And on the far right, there's a summary column which shows the total, through the end of July. As such, local emergency departments have reported a 31% increase compared to the same time period last year. Another way to look at it, it's about 35 non-fatal overdoses to the ED a week.
Josh, that's spread over how many emergency departments on average?
Okay, so that's a great question. So with this particular data source, our emergency department data, that represents 7 of the major hospitals in town.
To exclude anyone that?
Yes. We name hospitals. Yeah, so notably missing from this is Vanderbilt. So it's all the 6 major and then Nashville General, but excluding Vanderbilt.
So it could be a little underreported.
Definitely.
Okay.
Yeah, we don't know to what extent, but yeah, it's notably missing.
Okay.
So, yes. So on this slide, great question, Bob. The figure below here is our.
Could I just jump in? Why is Vanderbilt not in it?
And it's,
Maybe James can tell us.
that's a great question. This has been this has been in the works since before I worked at the health department. They've just never been, we thought we were ready to have them more from an IT stance, on board into the syndromic reporting. But that it hasn't happened yet. We've held meetings. It just hasn't happened. I'd be happy to talk more about it offline, but we've definitely been wanting to get them on board, because that's just apart from just, it's syndromic surveillance. So it covers more than just overdoses. It's, ILI, it's, infectious disease, so on and so forth. So like, that's a big deal for us as a county, so we can be more aware. But albeit said, they're currently not reporting into that system.
Okay, thank you very much.
I can speak to it real fast. I was just made aware last month, and it's being worked through all the necessary channels. I know that you all have been working on that for longer than that, but it was, we have many reporting databases, and we're participative in others, so it was a question that I had as well. So we'll get an answer back to the team.
Yeah, Jameson, thank you. And again, I raised it because I think it's just important to make sure we know those data included, and those data not included, especially when they're when the possibility is underreporting, because we want to make sure we're accurately capturing, what we think the current count is and risk, especially with fatal non-fatal.
Yeah, and I would just say two things to those points is, to Vanderbilt's credit, we were starting to make leeway, like having meetings pre-COVID, and then, but also from a surveillance standpoint, I do feel good about where we're at, our ability to understand what's going on. But yes, it is something we would all like to have in the future.
Jameson, thanks for your follow-up on that.
Okay, so let's shift quickly to our suspected drug overdoses, or those requiring response by Nashville Fire EMS. Again, these are up 42% at this time compared to the same time last year. Additionally, another metric we monitor is the number of naloxone administrations per patient by EMS. And this metric has increased since about summer of last year to over 2.3 administrations per patient is where it's currently at, 2.3. And we suspect this indicates stronger drugs and narcotics in the community. We see that through, obviously, the fatal overdoses with the amount of fentanyl just in the drug supply. And so last side, we also continue to monitor trends regarding race. This is just looking at our fatal overdoses this year and then also last year. And so among these, the majority of deaths in both these years occur among the white population, followed by the Black and African American population. You will see a slight shift in the proportions there between, especially among the Black African American population, of 21% to 26%. Again, the year's not finalized yet, but especially during the months of March and April, we saw an uptick in deaths among this population. And amongst those deaths, fentanyl was present in over 85% or of those toxicology reports, which is above average for us, which is definitely alarming. And then also by race, we really observed similar trends amongst our non-fatal drug overdoses. So that's my piece. Thank you for your time. If there's any additional data, again, that you would like to see, we have our contact information on a slide, so just reach out. Thank you.
Back to me. Thank you, Josh. Also very quickly wanted to run you through some of the work and the interventions that we're trying to get up and running now. So currently, the Health Department participates in two main grants. One is the Department of Justice Comprehensive Opioid Abuse Program grant, or the COAP. I know a lot of you are familiar with that one. We are going to be using that grant to get a fatal overdose review panel up and running. Obviously, we want to use this to better identify opportunities to intervene and save lives with others who are at risk of fatal overdose. We will be facilitating regular stakeholder meetings where we can share the kind of data and information and reports, things like you just saw, to try and better direct resources and interventions in our community. Again, with COVID, we're going to have to rethink about how we hold those stakeholder meetings, but we'll get it figured out. We will be continuing to use this grant to develop the surveillance system, which has been built from scratch. It has taken a lot of effort to both identify, gain access to, and combine these data sets. We're continuing to explore how to use these to identify trends and patterns related to overdose activity. The second grant is the Tennessee Department of Health CDC High Impact Area Grant, or HIA. The high impact area for Middle Tennessee was defined by the Tennessee Department of Health as the counties in Middle Tennessee that on a regular basis see most overdose activity. With this grant, we plan to replicate some of the efforts that we're going to be doing under the COAP grant with 3 additional counties, Montgomery, Cheatham, and Rutherford, partnering with the Mid-Cumberland Regional Office to do this. We'll be assisting in facilitation of multi-sector stakeholder meetings in those additional counties. We'll be expanding our surveillance and reporting activities to cover these additional counties. That's helpful for us here in Davidson County, as any overdose in any of the other counties impacts to all of the counties around it. The grant will fund a position with our Metro Health Department clinics that will assist in identifying those struggling with substance use disorder and to link them to treatment where possible. And this grant will also fund a post-overdose follow-up effort. This will include a position with Nashville Fire Department, EMS, and positions with Mental Health Co-op to rapidly identify and link to treatment at-risk clients post-engagement with our EMS for suspected overdoses. Some additional activities that we'll be doing across all of these grants, devising an acute overdose response plan. This plan allows us to use surveillance activities to identify overdose spikes or unusual patterns, to alert key partners in a timely manner, and to direct resources to address that activity. Key partners to alert through this might include first responders, hospitals, naloxone distribution organizations, access points to treatment, that kind of thing. A response plan will be developed for all of the HIA counties. ODMAP, this is a system that some of you have heard me talk about before. This gives us a close to live feed where suspected overdoses coming from the EFR EMS system are mapped. We got this implemented in June of this year after a lot of work to try and get there. So Josh and I now have access to a live mapping system, and we are now just trying to figure out how we roll that out to use it with key stakeholders to, again, direct resources to hotspots in a timely manner. The system also has an inbuilt spike alert function that we're currently looking at to see if we can automate notifications to key partners if there's unusual overdose activity. I'm going to mention our overdose surveillance system once again. It deserves that mention. It has been a tremendous amount of work to get that up and running, to access the data and pull it all together. The surveillance system itself is also, the reports we're able to put out through that are getting attention from other partners. So we've been getting calls from East Tennessee and the Dangerous Drug Task Force, and we've been assisting the Tennessee Department of Health Informatics Group to try and update people on a quicker basis as to what's going on with overdoses. So this surveillance tool is turning out to be very valuable. And we're continuing to figure out how to use that with just any community partners. Speaking of partners, over the past year in particular, we have spent a lot of time trying to build relationships, in particular trying to bridge between public health and public safety. If you read the 2020 National Drug Control Strategy, you can get a good sense of why it's important to bridge those worlds together to address the overdose crisis. We've developed great working relationships with many partners. Some of you are on this call and well, you can define if it's great or not. And again, I think all of our goal is to try and save lives. Our public health efforts have been recognized and valued from Tennessee Department of Health to the Appalachian high intensity drug trafficking area. Again, what has been unusual for public health in this effort is the extent that we have to develop the relationships with public safety and law enforcement while still respecting our particular responsibilities. These relationships ultimately lead to the sharing of information and resources to tackle this crisis. And here's how to find us and ask us questions and get more information.
Yeah, at the bottom is the website. We have a tab. If you just go to the Metro Health Department website, it's on the left. It's very straightforward. Just click on the link and you'll find all the reports through Q2 of this year. So that's all available as well.
Trevor, Josh, I've got looking at the overdose data. Can you hear me? Mary Lynn, and let me just ask this. And so looking at the fatal overdose data, right, trend, the 6-month trend is obviously pretty bad, dismal as we think about that same trend continuing to the end of the calendar year. Any COVID implications, thoughts? I mean, we seeing anything that you believe? What's making things look so different? One thing is fentanyl, right, is much more present than it was following that directly. So higher incidence of contamination by fentanyl. But are there COVID implications we need to be thinking of at the same time? That way.
Yeah. So the question was about how COVID has impacted what we're seeing here. And I don't doubt that there has been an impact. How much of that we can measure and attribute to COVID is kind of where we're at right now. But it's really important to understand how, if I did I kind of did a drawn out, but if I have a figure I did include on this report, which breaks down the percent of deaths have fentanyl in the toxicology report going back a few years, and it's just been ever increasing with the death. So knowing that, yeah, we can't, that's why I won't attribute a lot to COVID, because we know this has been going up. And
I think internally, I think that the term I've been using is maybe amplified what was going on already. Certainly, if we look at the numbers for this year ramping up, they do coincide with some of our social distancing and all of that. Again, you can't tie any particular case to that, but certainly something happened, and nationally, that is also true. But that we still always come back to fentanyl as being the thing that's killing people, because that we can see in the data, that we do know for sure. Mary Lynn?
Well, I was going to comment on some of the COVID-related causes and effects that TADIS has been talking about amongst its members, and that is that number one, not only normal quote unquote business has been disrupted, but also illicit drug trade has been somewhat affected by COVID. And so supply and demand being what it is, frankly, people are using fentanyl because supplies of other drugs and substances have become diminished. And that's why you're seeing an uptick in meth and methamphetamine, as well as with fentanyl. But one of the things we've been trying to promote that I think is a direct that helps counteract some of the COVID effects is that when people are more isolated and using alone and have less people around them, even if they had access to something like Narcan, you can't administer it to yourself, and you can't call 911 yourself. So the fact that people are more alone, that's having a direct result on the fact that we're having more overdoses because people are unattended and not able to be responded to. And one of the things we've been trying to push is co-prescribing of naloxone along with opioids and along with things like Suboxone, methadone, and Vivitrol, even Vivitrol, I would point out, so that people always have access to it and family members are given access. And I will say that TADIS is trying to push an initiative that would promote legislation for next session that would allow for easier access to naloxone. Tennessee is one of the few states where you have to have a prescription, even a standing order, to be able to get to access naloxone. And we're trying to promote legislation that would do away with some of those barriers so that the naloxone could be handed out more freely and people could have access to that life-saving medication. Sorry, I could go on. I'll cut it short.
Very well, that's great. Yeah, very helpful.
Other questions for Josh or Trevor this evening?
Quick note to Trevor, Josh, and the team. Got a quick answer from our legal team, and September will be set up. They've been working with Chief Informatics Officer at the Department of Health, and it's just a reporting system issue that it'll be ready by September. So it's good news. At Vanderbilt.
Thanks, James. That's great news.
One additional note, speaking of Vanderbilt, it's an area that we've been focused on is making sure that, in each of our access points that we have the ability to prescribe buprenorphine and getting into treatment programs across the board, knowing how many touch points there are and often being able to diagnose and really identify some of those risk factors. So that effort, I know, Trevor, we had mentioned kind of the ability to understand what's driving some of these, but we know that, the use of buprenorphine can decrease the use of illicit opioid use and retain patients in treatment, as well as high quality evidence for reduction in overdoses from the treatment. So making that consistent across the region, I think is an important goal for us. And obviously having those care pathways through MAT and other programs will be vital, but also just knowing that a lot of them are showing up in EDs, and often it's, I think there's data that shows up to 10% mortality after an opioid overdose that arrives in an ED from that presentation within a year of that time. So it's staggering numbers, and grateful for everyone in this room's partnership in helping us to address these really critical issues.
Anything else?
No, and again, just to remind everybody, Josh and I are available to each and every one of you individually, as a group. I mean, feel free to get in touch with us if you have specific questions. If you think we might have data that can help your work, please reach out to us. We're more than happy to talk to you at any time.
And if CWAC would like to be put on the list just to get the actual report when it comes out, we'd be happy to put the right members on that list and just go ahead and distribute that on an ongoing basis. That way you don't have to go look for it, but it would be in your inbox to be able to access.
Yeah. Thank you. Thank you both.
Thanks.
Thank you.
Thank you.
Your chair.
Like we're about ready to wrap it up. We have our next meeting is on your agenda. The reminder is October 1st, 2020. We will be extending invitations to ACE Nashville and CMHSI and to the opioid initiative as well for presentations. I am still of mind, and Angie and I haven't talked about it, but I think we'll still be reaching out to council members, again, in that champion role, afford you an opportunity for greater interface with ACE Nashville, with CMHSI, and the opioid initiative as our council champion, one or two champions for each of those groups. Do a deeper dive, get ready for those presentations, and then really be in a role to help facilitate that presentation to the council in October, or then maybe the meeting after October. But we'll be setting stage for that as well. Anything else for this meeting before we adjourn? Well, then, before we look for a motion for adjournment, Judge Callaway, happy Labor Day. Those of you that weren't on the phone earlier, a 17-year-old son at home today is having a birthday. It's Judge Callaway's Labor Day, so happy Labor Day. And early happy birthday. You said your birthday was Monday?
Yep, Monday.
If we're missing anybody else's birthday, now's the time to announce so you don't feel left out. We also know there's 3 Leos in the family. So All right, so happy Labor Day, and wish your son a happy birthday from all of us.
I will. This is perfect timing. I told him the meeting was at 6:30 and he'd have to have a 7 o'clock dinner.
We're only going to meet for as long as we need to meet. We're not meeting to fill the 90 minutes.
Awesome.
Anything else for this evening? How about a motion to adjourn?
I'll move.
Is there a second?
I'll second.
Everyone in favor? Thank you all. Thank you.
Goodbye.
This has been a service of the Metro Nashville Network. If you would like to see this presentation again, or for more information about this and other programs, visit Nashville.gov.